So we will talk on some of the pathology within those organs. So it is important for you to understand the development of the ovary, where you have the three sources in which you get the formation of capsule and stroma from the genital ridge. You have the sex cord from the epithelium, and then you have the germ cell arising from the primordial germ cell. So it is important to know that there are these three components inside the ovary, because the neoplastic processes that can occur in the ovary can arise from these cells. Okay? So what constitutes the ovary? You have the surface epithelium, and then you have the sex cord and stroma within the ovary, and the germ cell. And it is located in the pelvic cavity and covered by the peritoneum. So this is the ovary, that's the uterus, is connected through the fallopian tube, and then you have the ovary. Okay, so most of the ovarian pathology, they presented with an adnexal mass or cystic lesion. When you encounter a patient who presented with this, there are a few things that you have to consider clinically and within the history. Okay, so you need to look at the patient age, okay, whether they are young, within the reproductive age, or they are old and already menopause. Yeah? And then you need to look for any clinical features that are associated with hormonal abnormalities. Whether is there any hirsutism, whether is there any anovulation or abnormal uterine bleeding. Okay? And whether the lesion in the ovary or fallopian tube is unilateral or bilateral, whether there are associated effusion within the pleural cavity or ascites within the abdomen, whether the lesion is functional, they are producing hormone, whether they are single or multiple, and you need to look at the imaging studies, whether the lesions are cystic or cystic solid, or they are complex or a simple lesion. So these are the important questions that you have to think about when you want to consider what are the pathology that occurs in the ovary. Okay, because in the ovary, they commonly presented with cystic lesion. So the cystic lesion varies from non-neoplastic to neoplastic lesion. So you have functional non-neoplastic cysts, you have endometriotic cysts, and you have the neoplastic lesion that can present as cystic lesion. Okay? You can also have inflammatory lesion in the ovary, but they are not that common. And you can also have trauma, which usually occurs in a cystic lesion, in which they can become torted, so they can twist it and produce as a medical emergency, surgical emergency. Okay? Okay, the cyst, the non-neoplastic and functional cystic lesion usually presents with the changes of the menstrual cycle, and they are associated with hormone therapy, right? So the most ovarian cysts, the functional ones, they start during the normal function of the menstrual cycle. Okay, so this is called functional cysts, and you have two types, which is the follicular and the luteal cyst. Okay. So let's see if I can manage to open this for you, just to have a look at a video showing resection of a benign. I'm not too sure how to open this.
Oh. Abortion hari tu. Video. Tempat video. Video dia tayang video. Kalau video tayang waktu Afif cakap. Afif. Kaset dah. Kaset dah. Kita tengok. Tapi tak elak. Benci.
abortion.
What's that?
Okay, this is a
Direct
laparoscopic
abortion.
procedure. So you make a 3-hole
Asal
in the
macam basah.
Memang basah.
abdominal wall.
Okay.
You can see here there's the uterus, and this is a cystic lesion in the
cystic
ovary.
Oh, bestnya.
So they are reflecting the peritoneal covering.
Dia keluarkan sis tu lah.
Oh. Macam meatball.
Boleh nak submit tak? Boleh nak submit tak? Persevering. Ya, the ligament.
Cleaner dulu.
Sebab nak keluarkan air takut kan tak boleh kan. Kita kena keluarkan.
Susah sangat. Dia selepas tangan je lah. Ih.
Yes. Okay, macam mana jahit?
Dia tak jahit kan?
Dia buat
Kalau kau ini nanti dia
hilang sendiri. Kenapa macam berasa?
kenapa dia macam terpancing lagi? Tapi dia bukan binti.
Ya, dia tahu benda lain. Pasti, take it out.
Okay, the cyst is
Ya.
still intact where it is removed.
Tak, masalahnya macam mana dia nak keluarkan?
Ah. Tak apa-apa, keluarkan dulu.
Dia tak. Wah.
So
Oh.
you can see they contains a clear fluid, right?
It's a movie.
Clear serous fluid.
Dia bocorkan je.
Buat apa macam kan?
Kan?
Ya, dia siap bocorkan.
So the cyst is just a simple cyst, a very thin wall cyst. So the wall can be removed through the hole.
Maksudnya air kat dalam.
Air kat dalam kat mana? Menarik.
Dia tak vacuum ke?
So
Oh, yang kan dia macam suction je.
How it is removed laparoscopically.
Dan air.
Right?
Jatuh sendiri.
Okay. So the follicular cyst or the luteal cyst is the most common physiologic cyst in the ovary. So they arise from the unruptured Brachyan follicles or in follicles that have ruptured and immediately sealed. Okay. And this is aligned by the granulosa cells, which make up the sex cord cell. And they are usually multiple. They can be small, about 1 to 1.5 centimeter in size, and filled with this serous fluid. And they are lined by gray crystalline membrane. So what you see that in the video just now are the examples of cysts that can grow larger. So they can be larger, about 4 to 5 centimeters in size or even more, and can produce palpable pelvic mass and pelvic pain. Okay. Okay, corpus luteal cyst is another cyst that occurs as a change in the corpus luteum and can be present in the normal ovaries of women in the reproductive age. Okay, and they are lined by a rim of bright yellow tissue containing luteinized granulosa cells. So this corpus luteum occurs after ovulation, right? They form after ovulation. So you have to know the progression from the follicles until ovulation occurs. Occasionally, they can become ruptured and they can cause peritoneal reaction. So they can undergo hemorrhage, and when they become hemorrhage, they can contain hemorrhagic material inside the cyst. So distinction from an endometriotic cyst can be difficult. Okay. So the next one is polycystic ovarian disease. Okay, so this is a syndrome that is also known as the Stein-Lowenthal syndrome, and they are characterized by oligomenorrhea, obesity, hirsutism, infertility, ovary that has many cysts, right, and persistent and ovulation. And usually they came to attention after menarche in the teenage girls and young adults. So they contain numerous follicular cysts. There is no corpus luteum, okay, and they produces androgens and estrogens. So hirsutism increase in the male distributed hair in women, right? Okay. The pathogenesis of this polycystic disease is unclear, but it is thought to have due to the abnormal function of the hypothalamic pituitary ovarian axis. So it is proposed that the ovaries, they produces excess androgens which are converted to estrogen in the peripheral fat, and this inhibits the secretion of the follicular stimulating hormone, the FSH by the pituitary. Alright? So what you have is that the patient will have high androgen level, high LH level, luteinizing hormone, and low follicular stimulating hormone level. Okay? And this condition is also associated with insulin resistance. So the complications that can occur in patients who have polycystic ovarian disease is that they can have unopposed estrogen stimulation that lead to endometrial hyperplasia, okay, and endometrial adenocarcinoma. If you remember in your general pathology, in cellular adaptation, the influence for endometrial hyperplasia is in an excess of estrogen hormone stimulation. Okay, and then because of the insulin resistance, they are also prone to get type 2 diabetes mellitus and hypertension. Okay, so morphologically, what you see is the usually they involve both sides, so bilateral involvement. Okay, and the ovaries are usually larger than the normal size. And they are usually twice the normal size of premenopausal ovaries. And they appear gray in white with smooth outer cortex. And you see numerous subcorticals. So over the region of the cortex here, multiple subcortical follicles, cystic lesions in the ovary. They are not ovulatory, so you don't see the corpus luteum. Okay. Histologically, there are just fibrotic ovarian capsule with multiple cystic lesion lined by the granulosa cell.
Uneven surface.
Okay, the next one is endometriosis. Okay, so it's simply defined as the presence of endometriotic tissue at other sites other than the uterus. Okay, so it is also called endometriotic spots. So what are present in that site is the endometrial glands and stroma. So they are located outside the uterus. They are usually found on the surface of the ovary, in the abdomen, in the peritoneal cavity, or on the fallopian tube. Okay. So in the ovary, they can form a cystic lesion. Okay, so they are called endometriotic cysts. So what you see is a cystic lesion containing chocolate-like material. So it appears brown, dark brown due to an old blood. The contents are due to old blood. Okay. So on microscopy, for you to diagnose that this is an endometriotic cyst, you need to see two out of these three components, which is the endometrial glands here. You can see glands, and surrounding it is the endometrial stroma. Okay, and then you see all these single cells with brownish pigments inside it. These are called the hemosiderin-laden macrophages. They are engulfing the byproducts of the RBC breakdown. Okay, so hemosiderin. Right, so these are hemosiderin-laden macrophages. So it's either you have the endometrial glands and stroma, as well as the hemosiderin-laden macrophages. Endometriosis is very important because it is associated with an increased risk of ovarian tumors, especially the endometrioid and the clear cell carcinoma histological type. Okay, so you have a lot of histological types of ovarian cancer, which we'll talk about later. Okay, Okay, next we go straight to the neoplastic process in the ovary. Okay, so how common is ovarian cancer? They are the 5th most common cancer among women. So the first one is breast. So breast cancer is the number 1, but ovarian is the 5th most common. Okay, and the majority of ovarian tumors are benign and they tend to occur in younger women. And those that are malignant, they tend to occur in older women. So what are the risk factors for women to get ovarian cancers? First is nulliparity, being nulliparous, family history. So around 5 to 10%, not that much, ovarian cancer they are familiar with. So most of these are associated with the BRCA1 and BRCA2 mutation. Okay, and these mutations are also associated with breast cancer. Okay, and it is more so with the BRCA1, BRCA1 mutation. So the lifetime risk of ovarian cancer in BRCA1 carrier is about 30%, but BRCA2 is much less. Okay, but there are also tumors that is formed due to germline mutations occurring in the tumor suppressor gene, such as the p53 mutation. Alright. So in sporadic meaning the non-familiar ones, sporadic ovarian cancer, we do also found the BRCA1 and BRCA2 mutation, but not so much, and this occurs through a different pathway than the familiar one. Okay, so in other oral contraceptives also thought to be protective, or they somewhat reduce the risk of ovarian cancer. Alright, so we know the 3 components, cellular components in the ovary. So from there, we can guess what are the types of malignancy or neoplastic process that can occur in the ovary. So you have the surface epithelium, you have the germ cell, you have the sex cord and stroma. So from each component, neoplastic process can also occur. So this is the primary tumors in the ovary. But you can also get metastatic or secondary tumors in the ovary. Okay? So neoplasm of the surface epithelial origin account for the great majority of primary ovarian tumors. Okay? And the germ cell and the sex cord stroma tumors are much less frequent. They only constitute about 20 to 50% of ovarian tumors. So clinical features of ovarian neoplasm, again, we have to look at the first thing that I have talked about earlier. We need to know whether this is a solid lesion, whether is it solid or cystic or mixed solid and cystic, whether they are functional or non-functional, whether they are benign or malignant, whether you have accompanying ascites with it. Okay, because malignant ascites in a woman with ovarian cancer is an ovarian cancer until proven otherwise. Okay. And then you can send for tumor markers such as the CA125. If they are raised, they can suggest the possibility of ovarian cancer. And they can also be used for a follow-up marker, meaning once the tumor has been removed, you check for the level of CA125 to look for recurrence. If it raised again, it may indicate recurrence of the tumor. Okay, so the vast majority is derived from the epithelium. Okay, and with repeated ovulation and scarring, the surface epithelium can become entrapped into the cortex of the ovary and form the small cysts. So within these small cysts, you can get metaplastic change. They can undergo transformation, malignant transformation. So it gives rise to the different types of epithelial tumors. Okay, so benign lesion, they are usually cystic, so we call it cyst adenoma. Okay, and the malignant ones, they can become solid or solid and cystic, and usually they are the form of an adenocarcinoma. Alright, and some ovarian tumors, they fall into a a progression, a benign, intermediate, and malignant category. And those with the borderline category, they are referred to the tumors with low malignant potential. Okay, they are much more than benign, but they have a little potential to become malignant. Okay, so they are best considered as low-grade cancers with limited invasive potential. So they have a better prognosis compared with those of overt malignant ovarian tumors. Okay, so they can be asymptomatic or as an unexpected findings on abdominal examination or surgery. And the most common benign surface epithelial ovarian tumor is the serous cyst adenoma. The cysts in serous cyst adenoma are lined by a simple tall columnar epithelium, and they are filled with clear serous fluid. Okay, so they can be bilateral. Okay, so this is the appearance of the serous cyst adenoma. Okay, and they have a papillary formation lined by this columnar epithelium. Okay, mucinous cyst adenoma is less common than the serous, and they are less likely to be bilateral. Okay, so they rarely occur before puberty, and the majority of this mucinous cyst adenoma is benign, but they can be large, sometimes up to 25 kilograms in weight. And they are characterized by more cysts of variable size or multilobulated. And they are lined by non-ciliated mucin-producing columnar epithelium. Right? So this is the mucinous cyst adenoma, and the epithelial lining is slightly different from the serous just now because they contain mucin inside the cytoplasm. That's why the cytoplasm of the cell here appear clear. So this is just a comparison. If you can look here, those with the papillary projection or finger-like projection and the tall columnar epithelium, they are serous epithelium. Here, when you see clear mucin in the cytoplasm, this is the mucinous epithelium. Okay, so that's the difference. Okay, malignant ovarian neoplasm, they can arise from all those components that I mentioned earlier, and they can also be a metastatic. Okay, so serous papillary carcinoma derived from the surface epithelium is the most common malignant ovarian tumor. And the risk factors is incompletely understood, but the same thing, the nulliparity, family history of heritable mutation play a role in the tumor development. Okay, so this is just the morphology of the serous carcinoma or serous adenocarcinoma. Okay? So they form like a papillary or finger-like projection. They are malignant with variation in the size and shapes of the cells. So there are nuclear polymorphism. There will be prominent nucleoli. Okay? There will be hyperchromatism, increased number of mitosis. So these are all the features of malignant cells, right? But for papillary serous carcinoma, particularly they have associated classification which is called the Samoma bodies. Okay, so Samoma bodies are seen normally in serous type of malignancy. Okay, so these are the other histological types of surface ovarian neoplasm arising from the epithelium, right? So you have mucinous carcinoma, endometrioid carcinoma, clear cell carcinoma. So a lot of different types, histological types. Okay, the next group of neoplastic process that can occur in the ovary is the germ cell tumor. So these germ cell tumor, they constitute about 15 to 20% of all ovarian tumors. So they arise from the germ cells in the ovary. Most are benign cystic teratomas, and they occur in children and young adults. But there are also higher rates of malignancy, which I will explain later. Okay, teratomas or mature cystic teratomas, because they tend to be cystic in nature, and they are usually benign. The immature teratomas, if they have immature component inside the ovary, they are regarded as malignant. Okay, And then you also have the other malignant types of germ cell tumors, which is the dysgerminoma, choriocarcinoma, and pancreatitis. Okay? For the teratoma, they are mostly cystic. They are usually found in young women during active reproductive years, and they may be discovered incidentally or on abnormal radiograph. So they are characterized by the presence of mature tissues that are derived from all the 3 germ cell layers. So you have the ectoderm, the endoderm, and the mesoderm. So you have teeth, you can have bones, you can have cartilage, you can have hairs developed from these germ cell layers. Right? So this is the lesion, the mature cystic teratoma that can occur. Okay? So here is another lesion where you can see a few teeth, hairs inside it. Okay? Okay, so grossly they are unilocular, containing hair and sebaceous materials, but you also have other structures from the 3 germ cell layers. And these neoplasms sometimes can be complicated by infertility. Okay, they are also prone to torsion. Okay, and they can also have a paraneoplastic complication such as the limbic encephalitis, which can develop in women with teratomas that contain mature neural tissue. Okay, they have brain tissue inside the ovary. Okay, and in about 1% of cases, malignant transformation can be seen in the mature teratoma. Okay, because the skin is the most common structure that occur in mature teratoma. The skin contains the hair follicles, right? So the skin is composed of the stratified squamous epithelium. So malignancy can arise from the stratified squamous epithelium. So the most common malignant transformation is the squamous cell carcinoma. Okay. So whether you have mature or immature teratomatous component determines the behavior of it. So if they are mature, they are benign. If you have immature component, they are malignant. Okay. And the immature teratoma, they are often bulky with solid cut surface. Okay? And the distinguishing feature, as I mentioned, is the presence of immature elements, particularly the neuroepithelial differentiation, the immature neural component. Okay? So this is a mature teratoma where you can see skin here, the stratified squamous epithelium. And then you have the sebaceous glands here, you have fat, you have the cartilage. So this is a mature teratoma. On the right hand side, you have the immature cells. It doesn't form anything. It doesn't form any mature components. So this is the immature neural component in an immature teratoma. Okay. So you also have other malignant types of germ cell tumors. Okay, which is the dysgerminoma, solid appearance, occurs in childhood, okay, yolk sac tumors. Mostly patients are young, and children, okay. They respond to chemotherapy. For choriocarcinoma, okay, they are quite aggressive and usually metastasize to the lung. Okay, they arise from the trophoblast. Right? Okay, so this is just the appearance of the dysgerminoma. Okay, so the choriocarcinoma associated with a lot of blood hemorrhage. Okay, so this is a particular an important feature histologically that recognizes that this is a yolk sac tumor. Okay, right. So the next group is sex-cord stroma tumors. So they are derived from the ovarian stroma, okay, from the sex cord of the embryonic gonads. Okay. So they produce the granulosa and theca cells. Okay. Most of the tumors from the sex cord, they are benign and they tend to be solid rather than cystic. Okay. They are also functional, okay, because they produce the hormone estrogen. So they have symptoms that are associated with hyperestrogenism. So the examples of this group of tumors is fibroma, fibroticoma, and sertolioidic. Okay, granulosa cell tumor is the tumor that has a malignant potential. which derive from the sex cord stromal tumors. Okay, so this is the appearance of granulosa cell tumors. Okay, the next group of tumors in the ovary is metastatic tumors. Okay, metastasis can occur commonly from those of ovarian origin, such as from the uterus, from the fallopian tube. Okay. The extramural tumors are such as from the breast or the gastrointestinal tract. Okay. So we have a particular tumor that is known as the Kuchenberg tumor. This tumor is a metastatic carcinoma from the stomach that goes to the ovary, so metastasize to both ovaries, and it has a typical histological features. They are described as the signet ring cell tumor. If you look at the histology here, they appear like a ring. The cell looks like a ring in which the nucleus are pushed to the periphery. Okay, and the center is filled with mucin. So that's why it looks like a ring. That's why they are called the signet ring cell tumor. So this represents a metastasis from the stomach to the ovary, and it is called the Kuchenberg tumor. Okay, so we have finished with the ovary. So we are going to look at the pathology of the fallopian tubes. So you have a tubular structures that forms the fallopian tube. You have two sides to it, left and right. And inside the tubes, you have the plicae, that are lined by the respiratory ciliated epithelium. All right. So they are divided into a few parts of the length along the length of the fallopian tube. You have the fimbrial end, which is close to the ovary. You have the infundibulum, the ampulla, and the isthmus. All right. So what are the common diseases of the fallopian tube? Okay, a neoplastic process are not that common in the fallopian tube, but inflammatory process are common. So you can get salpingitis, or you can get tubo-ovarian abscess. Cysts usually due to developmental cysts. Okay, not that common. Ectopic pregnancy is another thing that is also common, and endometriosis. Okay, for inflammatory condition in the fallopian tube, you call it salpingitis. They can be caused by any pyogenic organism. Previously, the common cause is due to the gonococcal infection, sexually transmitted disease that causes gonococcal infection. But now the incidence of gonococcal infection is declining. So the non-gonococcal causes are the major cause now. So they can be caused by the chlamydia organism, Mycoplasma hominis, by the coliforms, and in the postpartum setting they can be caused by streptococci or the staphylococci. Okay, so the infections can be caused by that. So the complications from this inflammation of the fallopian tube is that you can get pyosylphing, in which you get abscess formation in the fallopian tube. Peritonitis, infection that spill over to the surrounding peritoneal cavity. Tubo-ovarian adhesion, so the infection from the fallopian tube can spread to the ovary, forming tubo-ovarian adhesion, tubo-ovarian abscess, and it will cause infertility because of the healing, the scarring of the fallopian tube will not allow for the fertilized ovum to be implanted in the uterus. Okay. So the non-gonococcal infection can penetrate the wall of tubes. They can give rise to blood-borne infection. Sometimes you can get the spreading of infection to the meninges, to the joint spaces, and sometimes to the heart valves. Okay, so the infection can spread. Right? Tubercular salpingitis is less common, but usually they are encountered with tuberculosis infection in other organs, in the endometrium as well. So the signs and symptoms are patient will present with fever, low abdominal pain, pelvic pain, or pelvic masses. Okay. So when you have adherence of the inflamed tube to the ovary and to the adjacent ligamentous tissue, this can lead to the formation of tubo-ovarian abscess. Or when infection subsides, they are referred to as tubo-ovarian complex. Okay? So this is where you tend to get ectopic pregnancy when the adhesions of the tuberclicae occurs, so it will block the fertilized ovum to become implanted into the uterus. Okay, so you get pregnancy occurs in the the pelvic tube. Okay, and when you have damage or obstruction to the tubal lumina as well, can lead to permanent sterility, and then patient can become infantile. So the inflammation of the fallopian tube can be acute or chronic. When it extends to involve the ovary and the other adjacent tissues in the pelvis, they are also known as the pelvic inflammatory disease. Alright? So for acute salpingitis, what you see macroscopically is an inflamed, swollen, erythematous fallopian tube, and microscopically there will be lots and lots of neutrophils. Okay, so the predisposing factors for this condition, for pelvic inflammatory diseases, is that when you have an ascending infection, okay, infection from down below, when patients undergo abortion, when there is the use of contraceptive devices, or when there is local intra-abdominal infection such as appendicitis. Okay, so this can predispose to the pelvic inflammatory disease. Clinically, they can be minimally symptomatic, or they can show a full-blown symptoms with fever, a high fever, nausea, vomiting, and severe pelvic pain. Okay? And sometimes they can be associated with vaginal discharge as well. Okay, the next lesion in the fallopian tube is paratuberculosis. Okay, so this is also known as hiatic cyst of Morgani. It's just a small cyst, okay, that is filled with serous fluid, and they are found near the fibulated ends or in the broad ligament. So just a simple cyst at the outer part of the fallopian tube. Okay, neoplasm of the fallopian tube, they are very uncommon. Okay, the benign ones are the adenomatoid tumors. They are derived from the overlying peritoneal lining, which is from the mesothelial cells. Okay, so this is arises from the mesothelial cells. They are actually a mesothelioma. Okay? They present as small nodules, or sometimes as an incidental findings when you remove part of the fallopian tube in a bilateral tubular ligation. Primary adenocarcinoma of the fallopian tube, so malignant neoplasm of the fallopian tube, are usually of an epithelial type, and it is usually of a serous or endometrioid histological type. They are much less common than ovarian tumors, okay, but seen in patients who have BRCA mutations as well. Okay, so it is thought that the sporadic ovarian serous tumor can also originate from the fallopian tube. There are changes in the lining of the fallopian tube that can predispose to, can become seeded to the ovary, that leads to the ovarian serous carcinoma. Okay, but this is still controversial. Okay, the malignant neoplasm of the ovary is the serous carcinoma. That is the commonest type. It has two types, which is low grade and high grade, because of the two molecular pathway, different molecular pathway. Right? Morphologically, you will see a mass at the fallopian tube, and patient can present with abnormal discharge or bleeding, and it can be very aggressive. It is of high stage tumor. Okay. Leiomyosarcoma can arise from the smooth muscle of the wall of the fallopian tube, but they are very, very rare. Okay, so this is a picture, gross picture of a tumor in the fallopian tube. Here also another tumor arising from the fallopian tube, and this is the same. So the morphology of the serous carcinoma in the ovary as well as in the fallopian tube are the same. Okay, the next pathology in the fallopian tube is ectopic pregnancy, which is fairly common. Okay, so it is simply defined as the implantation of fertilized ovum in any site other than the uterus. So they occur in 1% of pregnancies, and in more than 90% of these cases, the implantation occurs in the fallopian tube. Okay, so it is called tubal pregnancy. They can also occur in the ovary and the abdominal cavity. So the pathogenesis is that anything that stops the passage of ovum through the fallopian tube predisposes to ectopic pregnancy. And in about half of the cases, this is due to the inflammation and scarring of the fallopian tube due to the sarcoiditis or pelvic inflammatory disease that leads to the ectopic pregnancy. And in about half of the other cases, no anatomic causes is found. So we don't know what's the cause. Alright? So ovarian pregnancies can occur in which the ovum is fertilized just as the follicle ruptures. So they tend to be implanted in the ovary. Right? And when you have gestation in the abdominal cavity, this might be due to the fertilized egg that drops out from the fibulated end and implants in the peritoneal cavity. Right? Clinically, the human chorionic gonadotropin level is raised. Patient will have abdominal pain, and if the ectopic pregnancy ruptured within the fallopian tube, this can present as an acute abdomen. They tend to occur in the first trimester. Patient presents with amenorrhea and doesn't have any menstrual cycle for a period of time, per vaginal bleeding, palpable mass, and any symptoms common to early pregnancy. Okay, so when you do ultrasound of the abdomen, there is no gestational sac found in the uterus. Okay, so you have to suspect ectopic pregnancy when the UPT tests are positive, pregnancy tests are positive. So the risk factors for ectopic pregnancy is that patient has previous ectopic pregnancy, history of pelvic inflammatory disease, history of pelvic surgery, sexually transmitted disease, patient is under infertility treatments, okay, use of IUCD, and unsuccessful tubal ligation, or patient has congenital abnormalities of the fallopian tube. This is just to show how it occurs. Okay? Okay. So this is a segment of the fallopian tube that has been removed because of the ectopic pregnancy. Okay. So can you see in this picture? Can you see the fetus here? Yeah. Okay. So there are blood clots. So the fallopian tube is distended with presence of blood and the fetus. Here it has already become ruptured, and you can see the fetus inside the lumen of the fallopian tube. Here it becomes distended, and you can see the fetus in the distended fallopian tube. This is called the chorionic villi, which is the component of the product of conception. Okay, this is what you see on histology. Okay, so for ectopic pregnancy, most of the time they end up having surgical management, right? But there are, if you read in some literatures, they do mention something about giving a medication, medical treatment. But this is predominantly in those with early ectopic without unstable bleeding, and they give medication. But most of the time they end up having surgery as well, right? So it has to be really, that the diagnosis of ectopic pregnancy has to be very certain before receiving this treatment. Okay, but in terms of the surgical management, it's either salpingostomy or salpingectomy, which is a laparoscopic surgery that is used to treat the ectopic. When you do salpingostomy, only the contents of the ectopic pregnancy is removed. But when you do salpingectomy, you remove the section of the fallopian tube together. Alright? So which procedure that you do will depend on the amount of bleeding, the damage, or whether the tube has ruptured, or depending on the state of the under fallopian tube, normal or show signs of prior damage. Okay? So in summary, for the pathology of the ovary, so you need to know what are the common pathology of the ovary that can present with either cystic or solid mass. So the cyst can be non-neoplastic or neoplastic. Endometriotic cyst is also another common non-neoplastic lesion in the ovary that is associated with risk of ovarian malignancy. Okay. So the tumors in the ovary are derived from the three important components, cellular component in the ovary, which is the surface epithelium, the germ cell, and the sex cord and so on. Okay, and remember, metastasis can also occur in the ovary. Okay, for the fallopian tube, salpingitis is much more common. They are usually associated with sexually transmitted disease and associated with infertility. Okay, and if it involves the ovary and the other organs, it is known as pelvic inflammatory disease. Okay, cystic lesions are usually benign in the fallopian tube, and ectopic pregnancy is common. Okay, you have to think of that. And malignant neoplasm of the fallopian tube is rare, right? Okay, I think that's all. Thank you. Is there any questions? Any questions? No? Okay, if there's no questions, then we will stop here. Thank you.
Thank you, Doctor.
Thank you, doktor.